Hello, everyone, and welcome to Compassionate Conversations. I'm Tanys Coughlan from My Place Home Care, and I am joined by my beautiful co-host, Heidi Gagne. And we have two awesome guests for you today. We have Tara Cohen, and we have Lindsay Sabourin. So welcome.
Yeah, thanks so much for having us.
Thanks for coming. So Lindsay, why don't you tell us a little bit about yourself?
Yeah, absolutely. So my name's Lindsay Sabourin. I'm a registered nurse. And initially my nursing journey started at Rogers House, which is a pediatric palliative care facility here in Ottawa. But then I felt that there wasn't sort of enough acute skills right out of nursing school sort of being used there. So I went and started working at CHEO and then eventually found my way over to the Ottawa Hospital, working in oncology, the acute leukemia and bone marrow transplant unit. And that got really heavy. Palliative care wasn't always sort of referred to, or sometimes it sort of felt too late. So it got really heavy. And then I ended up going to Emerge just to sort of check out of the patient story and sort of take a step back. But I knew that palliative care would always sort of call me home. And so I started working for the regional palliative consultation team in 2022. And then from there, I entered into a palliative clinical coach role, which I've been in for the last year. So that's really supporting organizations in the Champlain region is where I focus, the Ottawa region, supporting organizations to look at what their current palliative practices are and helping support them, to improve, enhance their competencies and their confidence, to be able to have some of these discussions with their patients and just feel more empowered overall to be able to provide palliative care. So that's my role sort of in a nutshell, and a bit of my nursing journey in a nutshell, that palliative care sort of called me home, and it's really where my passion lies.
Awesome. Thank you. And Tara, please.
Yeah, thanks for having me today. I appreciate the opportunity to share what I've learned about palliative care. So I'm a social worker by training, and my role is the program manager at the Champlain Hospice Palliative Care Program. The program supports across sectors. We work with healthcare teams in hospice, hospital, long-term care, and in community. Our hope is to really improve and support teams to be able to deliver a palliative approach to care and end-of-life care. So the program doesn't specifically support individuals and families who are living with life-limiting illnesses, but we support the teams that do support those people. I guess I could also share that over the last 5 years, I've been spending some of my time collaborating with the team at the Centers for Learning, Research, and Innovation in Long-Term Care. So I've been spending quite a bit of time with them looking at palliative and end-of-life care, specifically in long-term care homes. And then finally, on the side, I do have a small private practice where I support people living with life-limiting illnesses, people who are dying, and people who are grieving.
Awesome. Thank you.
Lots of knowledge and learning in this group today. That is amazing. Yeah. I'm so glad you guys could join us.
Thanks, Heidi.
Okay, I said this in our podcast before. I'm relatively new to the healthcare world. I started with this company almost 4 years ago. So a lot of these terms and everything are very new to me. So I'm just curious, what is palliative care? When does it start? How do you know you're going to be in palliative care or you need palliative care?
Yeah, maybe I'll start with the palliative approach, Lindsay, and then you can pick up from there.
Yeah, sounds good.
So I think there's a lot of misunderstanding or a specific type of understanding around the word palliative. So I think people automatically associate it with dying, right? So people hear, we're going to refer you to palliative care, or right away it conjures up, I'm coming to the end of my life, and people feel afraid. Mm-hmm. So, we in the palliative care world, we talk about really to palliate is to soothe, right? It's to soothe and to support. We see, I would say over the last 10, 12 years, Canada in general has been moving towards language that sounds like a palliative approach to care.
Okay.
In many different settings. So the palliative approach is a philosophy, right? Okay. So it's a way that we could care for people who are living with chronic life-limiting illnesses. There still is palliative care, but the palliative approach has kind of brought in the idea that we could support people from a palliative approach much earlier in their illness trajectory. So I think we work really hard at trying to demystify this idea that palliative care is supporting people who are at end of life.
Right.
And that's, I would say, a big part of my role. So when you ask the question, Heidi, I think, how do people know when they need palliative care? Some of the language we've been using is that people could benefit from a palliative approach to care much earlier in their illness trajectory, soon after they're diagnosed, to explore ways that a palliative approach can help them as they move through their illness trajectory.
Right.
So that's some of the language I use. I think Lindsay has a bit of a different, a different perspective she could add.
Sure.
Yeah, I think it certainly echoes definitely a lot of what Tara has said, and that timing, and trying to get that timing right. Oftentimes in the healthcare world and in sort of like the patient caregiver world, there's a lot of misconceptions that palliative means end of life, and you speak that word into existence and it's going to maybe make death happen sooner, or it's going to put a bad omen on someone's sort of overall trajectory, that it's sort of a bit taboo in some ways, or it's believed to be taboo to bring up palliative care. But the way that I look at it is, it is that palliative approach, that philosophy that you sort of put this lens on. So you've got your cardiologist, maybe you've got your respirologist, all these different specialists that are involved in your illness. Then you can put sort of this palliative lens on of how you're sort of looking out at your overall illness trajectory, at your overall care. And it really is that palliative care comes down to, what matters to you? Who are you as a whole person? What are your goals and wishes? And how can we then tailor all these different treatments that you're receiving to, serve you better and to better align with what your wishes and goals are? So having that sort of lens over top, eventually it does sort of narrow down to we will end up at end of life. But, when is the best time to start? Early as we can, so we can have some of these conversations, when we're diagnosed with a life-limiting illness. We can look at, what does the science tell us of what is the overall trajectory? What does this timeline sort of look like? And then how can we prepare for, the hurdles that are maybe going to come and the steps that may be there along the way, and put this sort of palliative approach lens on and just look at, who am I as a person? What do I want my care to look like? What do I need people to know about me? What do I need my healthcare specialists to know about me that's really important to who I am, so that they can tailor their care and the care that I receive. It's not sort of a one size fits all. And having people feel empowered, having them be proactive in their care and just feeling in the know, rather than being in the dark and feeling like they need to sort of react when it does that shift of, maybe we're not active treatment anymore and maybe we're actually going to that end of life. Sometimes it feels very reactive and very like 180 switch for a lot of people. But if we integrate it, all the way through, then people maybe just feel a bit more empowered and a bit more in the know throughout their illness trajectory overall is the goal, when we put that lens over top of just who are you as a person.
That's a really great way of thinking about it, because then palliative isn't it's not as scary. It's more of like you said, empowering. It's giving the power back to you.
Yeah.
And allowing you to decide how you want things to go.
Yeah, absolutely. The one other thing that I might throw in there is kind of a foundational piece that we try to talk about is, I think, in the language that's been, the language that's been used around palliative care is that people become palliative, right? So there's kind of this history of, people working through the healthcare system and having different interventions, treatments, and then this idea, this person is now palliative. So we really, the language we use is quite different. We talk about it is not a person who is palliative, but the care we deliver is a palliative approach.
Yeah, that is, I'm thinking words mean so much now, and they have so much power. And I think, yes, as we become, more inclusive, more diverse, and all these terms are used in a more, not positive, but a more broad or
holistic, really.
Holistic, yeah, exactly. A holistic way. It makes it feel like a little less scary or a little less unknown.
That's what we hope. It's more supportive, less scary, more supportive.
And there's a lot more. It seems like there's a lot more supports now out there for people, and more options. So you can have the different kinds of care, or if you reach a stage and you decide, okay, I'm done. I don't want any more doctor. I don't want any more. I mean, that would be all part of the palliative approach, right? Because it would be what they want.
Yeah, and as Lindsay was saying, hopefully that there's already some connections made along the way with a palliative, either through a palliative approach, where a person is being cared for. So this is something else we talk about, that is palliative care, palliative approach to care isn't specific to one particular setting, right? Healthcare teams could deliver a palliative approach to care in home settings and long-term care homes, and in hospice, hospital. Like it's a philosophy, right? So it's not a particular location.
And so then, so we have palliative approach to care, and then there's hospice, which is, that's closer to end of life care, right?
Well, so I don't know, Lindsay, do you want to jump in there? Do you want?
Yeah, I mean, typically hospice, we do see like traditional hospices are reserved for when someone is in their final weeks of life, that it really is that end of life care that we've then sort of transitioned to. We can palliate people, we can have end of life care that happens in someone's home, in their long-term care home, because that's where they call home. The hospice facilities exist for maybe when it's not so feasible at home, or maybe when the caregivers are maybe just feeling a bit burnt out and they just want to take a step back. Hospices exist throughout.
But it's also important to know that hospices, so there's hospices that have beds where people go at the end of life, but many of the hospices in our area also offer programs, day programs, for people who are living with life-living illnesses long before they get to end of life.
Yeah, my dad is in one of those programs. So
yeah, great sense of community and just, connecting with others. And even, some will also offer like symptom management. So depending on the facility, some will offer, short stay symptom management to get someone's symptoms back under control with the goal of getting them back home. There's sort of unique offerings depending on the specific hospice, but a lot of community connection, a lot of often, community engagement that happens outside of most local hospices. Absolutely.
Yeah, and the programs, like the one my dad is in, it's very much about, giving him a safe place to go to get out of the house, because they get very closed in and not able to go to just everywhere. So for him, it's been
that's great, Tanys. Yes, the hospices offer like programs for people who are living with illness. They offer programs for carers. So there's a range of different support services, grief support. There's a lot in our community hospices.
Absolutely.
I think it's one of those things too, oftentimes patients feel bounced around in the healthcare system. And so, you're with cardiology, you're in this stream now, you're with your heart doctor, stay in this. Eventually we'll sort of then bounce you to those palliative people. And then it's sort of that uncertainty. People say, will they know my story? Will I have to explain this all again from ground zero, and sort of reiterate, what I am and who I am. But if we have it interwoven, then, maybe when the heart doctors are, signing off, it's like, oh, I know that I'm still well supported. I know my palliative team, they've been with me the whole way, maybe not following us closely, but I know them, they've been with me, and I feel, supported. I know who's going to pick me up, instead of saying, okay, I'm going to now go home and hope I get that call and see what that palliative team's like. I don't know anything about them. So I think there's a lot of beauty too when we interweave it throughout, that it sort of takes some of that ease off of patients, because there can be a lot of bouncing around, or, just waiting on appointments, or that uncertainty, which never feels great for anyone to sit with.
Yeah,
absolutely. Yeah.
I'm curious. So both of you work in palliative care. Lindsay, your journey in nursing has been all over the place. How do you both process what you see on a daily basis? We talk a lot about caregiver burnout, both in our own caregivers, like our staff, versus like family caregivers and everything. Like, how do you guys process or separate that on a daily basis? It's a lot.
Yeah, that's a totally valid question, right? And I had that point in my career, where I was working on a unit that maybe we didn't refer to palliative care as readily or as often. And it felt like it was sort of this very reactive, very 180 shift, that it felt heavy. And I did have to step back and say, this is a lot. But, you tell people right now, oh, you work in palliative care, and they sort of give you a bit of that pity look of like, oh, I'm so sorry, that must be so hard. But actually it's so rewarding. Truthfully, like when someone enters into the palliative world, we're giving them that palliative approach. I'm sitting with people and I'm listening and asking them, who are you? And they're like, wow, like no one's really done this. And I get it. There's time constraints, and I'm not sort of faulting anyone there. There's time constraints at appointments, but I sit with them and I just, tell me about you. Tell me who you are. That it's a very rewarding job. I've met some very interesting people who have lived such full lives and have done amazing things for Canada and throughout that, you know, finding the rewarding part of it, finding, you know, the positives in it. I can empower someone. I can help validate someone. I can help someone feel like they are heard, and taking, you know, great joy in that, and being able to, you know, sort of try to protect using colleagues and having debriefs. There's definitely been very difficult situations that I've been a part of, but leaning on colleagues and, you know, venting and normalizing, you know, it's okay to sort of feel emotions. I think it was taboo. It's getting better. It used to be really taboo. You know, as a nurse, you're not supposed to feel emotions when a patient dies because that means you're too close or like you got too invested or too involved. But I think that that's so very wrong, that we are human and it's impossible to not have emotions to it. That finding that fine balance and recognizing, you know, when you need to maybe step back. But yeah, speaking, using your colleagues, using different supports that are out there. Tara is definitely a wonderful colleague to have. Knowledge that she has and shares that, yeah, you know, team meetings and debriefing and knowing that we are human and it's okay to feel those emotions. It didn't mean that you were too invested. It meant that you were human and you had a very real experience and a very real sort of emotional reaction to what was occurring.
Well, and I think that's something that maybe, you know, people don't, we need to shift to that. The fact that, you know, we are all human and we need to feel that. And the more we can allow people to be that way, I think it will definitely reduce stress. And I don't think it's just related to even, you know, the palliative field. I think all of healthcare.
Across healthcare.
We need to bring the humanity back.
Yeah.
There seem to be a lot of, you know, like, well, doctors are infallible. They shouldn't be making mistakes. Nurses shouldn't be making mistakes. It's like, no, but they are human. Yes, they have more education than the average person, but that doesn't make them that they can't make mistakes. Yeah.
Or feel things more generally. Right?
Exactly. Yeah. Or feel things.
I could share a little bit about, so for me, in my private practice, I'm sitting with people who are experiencing suffering, who are living with illness, who are dying. And I would say that the way I care for myself is by allowing myself to feel. Right? I think it's okay. Like, you know, there are plenty of times that I have tears with people and, you know, just, so yeah, sitting in that together, I think is part of the way that I care for myself. And then there's some other things I've learned to do on the side, which also is a main part of my role at the Champlain Hospice Palliative Care Program, is working with healthcare teams. So I've developed resources over the years, along with my teammates and, you know, my colleagues, and we spend time working with healthcare teams, offering workshops on self-compassion.
Okay.
So we do this within hospitals and hospice, long-term care, community groups, going in and doing like 1 hour, 2 hour workshops on how to be kinder to ourselves. Because I think healthcare providers put a lot of, just expect a lot of themselves, right? And it's like to show up in a professional way and to do everything right. So yeah, thinking about self-compassion, we go through like the 3 domains of self-compassion that have been sort of talked about in the literature in terms of being mindful, which is noticing what you're experiencing. Talk about self-kindness, how we could say things to ourselves that we would say to our best friend, not focusing on the things that didn't go exactly as we wanted them to be, but, you know, really the same advice you give your best friend. You did your best. You are enough. You know, you've done everything you can. And then third is common humanity. So I think, you know, again, Lindsay kind of alluded to this, like the common humanity piece is knowing that we are not alone in our struggles.
That's right.
Having colleagues that, you know, we can connect to, and, you know, so in all the healthcare teams to know like who's around them, who they can lean on, you know, the shared experience of supporting people in illness and dying. So yeah, so we do a lot of work around self-compassion for healthcare teams. We also We would do debriefing for grief, recognizing that it's completely normal for healthcare providers who are human beings to feel grief after caring for people.
That is a real thing. And in my personal experience at this time, we have lost, since I started, we've lost a few. 1 year we lost 3 clients in very short succession. And I mean, I'm not out in the field. I will sometimes do companion work if needed, but I'm not generally out in the field. But I've mentioned this before on our podcast. I read all the shift notes from every single caregiver. So I read everything. And I mean, I talk to our caregivers about clients. I talk to their family members. I talk to the client themselves, depending on their situation. So I really feel like I get to know them, where I might not see them every single day, or I might not be with them physically. I know everything. And there are times where I've gotten off the phone and just sobbed because somebody has shared something with me. Or I was talking to a client whose husband had dementia, and it became too much for her. She had her own healthcare issues, and he had to go into assisted living, and he passed about a month and a half later. And I was talking to her, and she was like, "It's all my fault. I did this. He should have been at home with me. It wouldn't have happened this way." And I'm like, but you're doing what you can with the information you have at this exact moment, and your own health, your own needs, which are just as important, and everything. And these were the choices that you made with the information that you had.
Yeah. So I appreciate that. So right. In the moment, you're able to support her, right? Because you're showing up to offer that support. But then your heart is heavy too, because you know they're suffering.
Yeah. And then I remember getting off the phone with her and just crying because, I mean, I'm trying to keep it together to be the calming presence for her. But but you're saying, just like you would talk to your girlfriends and support your girlfriends. You're so right, because I've said the exact same thing to my girlfriends, going, you're doing what you can do with the information you have right now. That's, I mean, I don't know how else. What else you could say at that point, because that's all you can do.
Well, that's being human.
And then, that's right. Yeah, and then to offer the same thing to yourself, right? After you had that experience, that conversation, to then say to yourself, that was hard, this hurts, but I'm doing the best I can. And then the next thing that we kind of play around with is like, what do I need in this moment to support myself?
Yeah.
Right. You need to step outside and get a little bit of fresh air. This is this is how we palliate ourselves as healthcare workers, right?
Yeah.
Right.
How do we reduce our own suffering? What do I need? Right? Do I need to get some fresh air? Do I need to talk to a friend? Do I need to, do some jumping jacks to get my body moving? Like, everybody has different things that supports them in the moment. And I think, as palliative care teams, we look to care for others, but we also have to turn that to ourselves. How do we do that same for ourselves to keep doing the work?
Yeah, I'm really pleased that we're going this way. I know when I was in the field, so I've been in the field for 30 some years. And when I started in the field, it was like, you can't be friends with your clients. You need to be professional, which means, no emotion. And so for me, and I'm an emotional person. So, that was a hard thing for me. I ended up with burnout because I was trying to be all professional and hold it all in. So, I'm really pleased that the whole system is moving towards this kind of approach, a more open and emotional friendly approach.
And we're allowed to show emotions.
Yeah.
We hope so. And I think, because grief is a big topic these days, we hear a lot about disenfranchised grief, right? So I think, healthcare organizations are starting to understand that if healthcare workers' grief is not recognized and addressed, it becomes disenfranchised grief, which like the research has shown, leads to absenteeism and burnout and moral distress. So my hope is slowly but surely.
So what does that show up as? How do you pinpoint that might be happening with the
disenfranchised grief? Is that what you're asking? Yeah, I think sometimes it shows up as stress, disengagement, disillusionment, creating some walls between yourself and the people that you're supporting. Yeah, and then it does lead again to things like I mentioned, like absenteeism and sick leave and things that are undeniable.
Mm-hmm. Yeah.
I think shifting to there is that very real healthcare side of it, but then you see caregivers and loved ones like that call that you had, Heidi, where, they're sort of questioning, did I do the right thing? And that guilt and that burden that they live with. And maybe for that situation, maybe it felt like, going into the home was too late. And it was sort of, I wish I had done this sooner, maybe, because I feel like I just don't even have time to process it all. And that's where, we hope that palliative approach, when we're integrating it early, when we're talking about things like advanced care planning, when we're talking about goals of care conversations, when we are talking about who you are as a person and what you want your care to look like. So often I've seen loved ones say, I hope I'm acting in mom's best interest. I don't actually know what mom wanted. We never had these conversations. I think this is what she wanted. And then you see people who have had an early integration of a palliative approach to care. They've had this right from the start. They've had big, heavy conversations that are hard conversations to have, but necessary. They say, hey, I know what I'm doing. I know what my decisions are. I don't have to have, some of that heavy burden that's sitting of, is this the right decision? This is what mom or dad wanted, and I'm acting within their words. This is what they told me they wanted. And it doesn't take it away completely. Death is still hard, and there's still a presence of grief that happens. But, that palliative approach sometimes can shift us. When I talk about, being proactive, being in the know and being in the light, that it can help sometimes with that grief that comes afterwards to say, this is exactly how mom wanted this to play out. There was hurdles along the way, and there was things that we maybe didn't always expect, but I knew exactly what she wanted, and mom was empowered. She knew what she wanted the whole way. She knew what was sort of roughly coming in her illness trajectory, and she acted, and she was empowered, and she felt informed and like she was an active participant in her health. So that palliative approach can really help when we integrate it early, with that grief process as well, taking some of that burden. Like I said, it doesn't eliminate, there's still grief for sure, but taking some of that heavy burden of uncertainty and wondering and wishing, it's heavy to sit with afterwards.
Right. We sometimes talk about it as we call it a path of least regret.
Mm-hmm.
Right?
Okay.
Yeah, I like that.
Having these conversations early, like Lindsay said, and then it's co-creating, right? This experience, and hopefully it's contributing to a path of least regret for people.
So if somebody it's been decided, or I'm not, so I'm assuming that somebody is in a life-ending illness, and it gets to a stage where there's obviously no,
Sure.
Unfortunately, we've had people call and say, my uncle needs help because the hospital says there's nothing else they can do for him. And that just feels like a horrible way of saying it.
Mm-hmm.
It's
not like,
all right, we're done. We're done. Like, can't do anything else.
Yeah. We always say there's always something there's something, right? Like a palliative approach to care is not doing anything.
Maybe there's nothing medical at the moment, but there must be other support. So you would think, if the hospital is saying, technically speaking, medically speaking, except for pain management, there's really nothing else we can do. How, as somebody or a family member hearing this, can they then say, he should already have a palliative team? Because we, again, had people calling us and saying, no, we don't know anything from the hospital. They haven't said anything. How does one go about and almost demand a palliative team that can help you help you with these things?
Mm-hmm.
I would say the first thing that comes to my mind is ideally the message that's being transmitted to families is not that there's nothing else we could do. What I would hope is that the message is more around, we're going to shift the focus from curing to a palliative approach.
I hope the term would be used, but I have heard them say there's nothing else we can do.
For sure.
And that's terrible. That is disheartening and heartbreaking to hear that.
Yeah. Mm-hmm. Lindsay, I don't know. Do you want to sort of talk from there?
Right. I feel like I frequently see that, people go from, I've got my monthly oncology appointment and I've got my frequent scans, and then all of a sudden they're just telling me that they can't see me anymore. There's nothing more that they can do. And I don't know where to go from here now. I don't know what to do. And it's so overwhelming. And, sometimes they've heard of someone in their family that helps them navigate, but it can feel like a bit of a secret society sometimes. I feel like even being in it, like I learn of new organizations that exist all the time, but finding the local resources that there are to be able to help navigate. And I know that there's people who are not just in the Ottawa area, but helping advocate of this is what I'm noticing, and getting things like home care in place for a care coordinator to be in there and having the discussions with them of what resources are there, what's available to me, reaching out to your local hospice, and seeing if there's a nurse navigator. Is there day programs? What services do you have? Organizations like Access CSS have a ton of community support services that they're sort of a centralized all-in-one referral system that can help with navigation. Things like the Champlain Hospice Palliative Care Program. I mean, it's Champlain is in the name, but their YouTube section, like it can feel like sometimes you need to sort of educate yourself and be the advocate for yourself. And I wish it was a bit more freely offered within the healthcare system. We're changing for sure. We're getting more out there. But that reactive, all of a sudden there's nothing to do. And then you're just feeling that lost feeling. Yeah. Connecting to home care, connecting with community supports, figuring out what's local in the area. Access CSS is across the province, and trying to help resource, chatting with other people who maybe have been through something similar, but it can feel like a secret society. It's overwhelming to try to figure it out and navigate while you're also still actively caring for someone too at the same time.
Right.
Yeah. And one more thing I would also, Lindsay sort of captured it in community organizations, but yeah, like I've noticed for a lot of people, it's really helpful to have a connection with different organizations that support the illness that a person might be experiencing, like the Dementia Society or ALS Society or Parkinson's groups, or those are really great resources. They often understand what a palliative approach is and have specific information about that specific illness trajectory, along with like different supports, like built-in supports of people who are experiencing something similar. So they're another great resource.
Are a lot of these supports that are out there, do they cost money? Like, I mean, I know a lot of people I can't afford anything. So what kind of
are covered? A lot are covered, like OHA, Ontario Health at Home. So that would be sort of local to the province of Ontario, but Ontario Health at Home would be covered. Patients can self-refer. So if they say, I don't have a family doctor, the cancer center has sort of said that there's nothing more that they can do. I don't know who's leading my care. They can self-refer to Ontario Health at Home. Access CSS is another organization that they can self-refer to for getting through. But yeah, most are covered. I would say a fair bit are covered. It's sort of when you look at private duty nursing and sort of that 24-hour coverage of care, that's when we end up with sort of private pay options. But yeah, community-wise, there is quite a bit. And like I said, I feel like I learn something new every month of a new organization that are covered.
Well, that's good to hear.
As well as hospice programs. Hospice programs are generally, there's no cost. And again, those specific organizations for different illnesses. So yeah, there's quite a bit out there. But yeah, again, if somebody's has advanced illness at home, as Lindsay said, there's, like the private nursing at home is, there's cost there.
Yes. Well, I mean, we've supported end of life
for sure.
In the past and everything like that. So yeah, and it is difficult. And I sometimes wonder, I mean, if you need somebody around the clock, that's not cheap. That's like $25,000 a month to have somebody 24 hours a day.
Yeah. So maybe there's one other thing. So hospices often have volunteer visitors who could come depending on the needs of the person at home, right? So if the needs are too intense, then that might not work. But, very often the volunteers are able to come and see people who are at home living with illnesses.
Oh,
Right. And like community plays a huge part. Like it's certainly the people who feel like they don't have that sense of community. They struggle more so when they don't have people to sort of call on and lean on, or they feel like they're sort of burdening others. But then I've seen patients, you know, who have a wonderful sense of community, whether it's a church community or something sort of non-religious, that, you know, creating calendars of shifts of, you know, I'm here to help, but maybe it's only once a month that you need me. And that's totally feasible. I can fit that into my life. And if it eases you and helps you out, then it's sort of a win-win. So, you know, I see people often afraid to sort of ask their loved ones, but having something that feels manageable, you know, a weekly shift or whatever it's going to be, trying to band everyone together and have that sense of community. But, you know, I've seen patients say, I don't want anyone in, I don't want to talk to anyone. And they really sort of shut down. So trying to explore that with them, but community is a big thing. Establishing that community, you know, while you're early in an illness, getting involved with, you know, like Tara was mentioning, different disease specific societies, to, you know, get some support groups going on. People there are usually a wealth of knowledge. And having that early integration, reaching out to these organizations early so that, you know, when that reactive moment comes where all of a sudden I need everyone that I've been looking into, that we know where we're turning and we're feeling empowered and educated, because it's easier to do it when we are feeling like things are sort of okay right now. But when it's that tsunami wave coming to hit us, it just feels so overwhelming to even pick up the phone and try to make a phone call and formulate, you know, a sentence or a thought about what I need in this moment. It feels like if I just put my head down and just keep working through this, something will sort of figure itself out, because it's too overwhelming to make a phone call.
100%. And I've had those phone calls. And I think recently, I think I've had 2 intakes where we go over the client's needs and everything. And they started crying. And I was just like, okay, this is the first time I've dealt with this. But, you know, one was dealing with a life-limiting illness. And it was starting to impact her life. And the journey that she had been in to discover what it was, let alone knowing what it is. You know, it was a 3-year journey of just getting that diagnosis. And then that diagnosis hits you. And then what do you do?
Yeah.
And I mean, I don't know. I guess at that point, what I know now, if I got that kind of life limiting diagnosis, I'd be like, okay, let's get my palliative care going. So I know what I'm dealing with. I hope that's how
that's why we love these conversations, right? Because this is the reality. Like we all experience, you know, illnesses in our lives or the people around us. Like none of us gets through our lives without having encounters like this, right?
Yeah.
So we think these conversations are super important. And then we know, like we've heard, you know, from so many people that it is hard to ask for help.
Yes.
Right. We're in a society where we're sort of praised on being independent and strong, but for whatever that means. But it's hard to ask for help. And we have colleagues who have, you know, done research in this area, supporting people on how to ask for help. So, you know, a couple of the little tricks that we talk about are just remembering how good it feels to offer help to people that we care about. Right. So, you know, when things shift and, you know, you are now a person who is experiencing illness and needing help, remembering how good it felt to be on the other side and trying to use that as motivation to ask for help, because people generally want to help a person who's experiencing an illness, but they're not sure what to do.
Or exactly. How do you, what do you need? But then the person's like, I don't know.
I was just going to say,
I've never been here before. I've never done this before.
So that's another good point, Heidi, right? Like sometimes people don't know what they need, right? So, you know, there are apps, which, you know, like where, as Lindsay was saying, like in organizing when people are living with an illness, you know, different ways to get family and friends organized. So there are apps to do it. We actually have a resource on our website, champlainpalliative.ca, under the families and caregivers tab that, just sort of like starting to formulate ideas even before you go ask for that help, is knowing who's in your circle and what they could offer, right? Do you have someone that's really good at practical things like, going to the bank or walking the dog or putting up, holiday decorations? Do you have somebody who's really good at listening? Do you have somebody who's, somebody who's
likes cooking and
exactly all these different skills, right?
That's always my first thing is I go to food. I'm like, I'll make you food. I'll make you cooking, make you dinner, whatever. And
sometimes you have like, a wife and a husband, and the husband very much played his role, and he was the handyman and he was the fixer, and not to stereotype people, but they really struggle. That wife that was the caretaker, the cooker, she's sick now. And so, he, as the gentleman that was the fixer and the doer, is now struggling with, what do I do? Like, not even knowing what it is that is missing. But you can see that generationally, I feel like it's getting better. There's a lot more like jointness in homes, but you have very much people who play very specific roles in their homes, for sure.
Yeah.
My husband has said many times that I cannot go first. The roles that we play. But yeah,
I agree. If something happened to my husband, I would not be living in the house that I'm in right now, because we have a pool and he just built a new deck and a pergola. And I'm like, I wouldn't do that. That's not in my purview at all. Yet he would be eating cereal and, bananas and peanut butter wraps every day if it wasn't for me. And it's not saying that we can't do these things. It's just, these are the roles that we've taken on in our relationship. And there's a lot of things. I'd be like, okay, I'd have a really cute apartment with my dog.
Knowing furnace filters get changed, and if you're someone that maybe it's that the predominant male in the family is the one who's sort of facing an illness, just going around the house and figuring out what needs to be done, like not necessarily asking what can you do, because they may not know about furnace filters, and something that seems so easy can go a long way ultimately.
Right. Yeah.
Well, and that speaks to the fact that when you're going through this, not only are you dealing with the stress of whatever the news is, but you're also on a learning curve to learn how to do all these other things that you didn't have in your daily calendar, like the furnace and for me, like grass cutting, and we have a pool too, so it'd be the pool thing too. So, but all of a sudden, you're like having to learn how to do this, but your brain is focused on your loved one and caring for them. So,
and like when you have the conversation early, and when you say that word palliative, we're taking a palliative approach to your care, you can start people preparing of like, okay, so it seems like my loved one is maybe going to reach their final moments at some point with this journey. I should maybe start, taking some things over now, or learning some things now. I lost my own dad about 13 years ago, and I feel like palliative was never mentioned. He was stage 4 on diagnosis. But palliative wasn't mentioned until it was that very much reactive. There's nothing more we can do. There's no more treatments. Here you go. Here's a referral to hospice. Best of luck out there. And I feel like there's so many things that I would have loved to ask him and love to know. And, when we talk about that palliative approach early, when we normalize it, when we validate what is going to happen, when we anticipate and help people through that, if I had asked that doctor, are you surprised that my dad didn't last this long? They probably would have said, no, like, I'm really not surprised that we've ended up here. But to me, it was a big shock. I was very much reactive. So when we normalize it and validate it early, we allow people to start having those conversations sooner of, what does this role that I'm about to take over look like? What do I need to, start asking? What do I need to know when I'm in a state where I can, take in that information, and I can maybe take on some things and learn some things along the way. Versus, oh my gosh, we're now palliative. I don't know what to do. I have to learn all of these. The banking's due tomorrow. I've never done this. Like, it's just so overwhelming in that moment. But when we talk about that early integration, early conversations, early planning, we just allow more time for families to adjust, for loved ones to, get ready for what's coming and what will eventually come, and they can feel better prepared.
Yeah.
I think while we're talking about having conversations, it's probably important to go back to advanced care planning, because I think there's a lot of misunderstanding about advanced care planning also. So in the work that we do, we often hear people say, oh, I've done my advanced care planning, I have my will. So, again, just
Good
to clarify.
Good step, first step. I'm sure there's more.
There's a lot more. Yeah. So really, when we talk about advanced care planning, we're really talking about the piece that it's important for people to know that in Ontario, everybody automatically has a substitute decision maker. Right?
Okay,
So
I was reading that on the website this morning. What is a substitute decision maker?
Yeah.
How do you automatically have one?
Yeah. So again, I don't know if your audience is largely in Ontario or if it's from all over largely. Yeah. So in Ontario, we have the Healthcare Consent Act, which is laid out in the law, a hierarchy. And in the hierarchy, there's 9 different lines of who would be your substitute decision maker if you could not speak for yourself. So if you were to be in an accident on any given day and were in hospital and couldn't make a decision on that day about your healthcare, your substitute decision maker would make a decision on your behalf.
Okay.
If you had a chronic life-limiting illness and you were, at a part in that illness where, again, you couldn't make a decision for yourself, your substitute decision maker would make the same healthcare choice for you that you would make for yourself. That's the goal of the substitute decision maker, to make the same choice for the person as you believe they would make for themselves.
Okay.
Right? So you're acting in the best interest of the individual who cannot speak for themselves. So what we say about advanced care planning is that it's not consent in the moment, it's consent for the future, but you have to talk to your substitute decision maker about what's important to you, because if they don't know, if they don't really have a sense of what's important to you, it's really hard for them to make a decision for your healthcare. Right? So yeah, advanced care planning is these 2 pieces: knowing who your substitute decision maker is based on the hierarchy.
So sorry, what's the hierarchy?
So the hierarchy is these 9 different lines. So the first line is, do you have is a guardian, right?
Okay.
So let's just we'll flesh it out here. So an example would be, if I was in hospital and I was unconscious and couldn't make a decision for myself, the healthcare team would want to know, who do I go to for a decision about possible treatment? So they would have to go to my substitute decision maker. So they would take out the hierarchy and look at it. And the first line on the hierarchy is a guardian. So they would wonder, do I have a guardian that's been legally appointed? The second line is a power of attorney.
Right.
So the power of attorney, I think, in healthcare, again, sometimes we mix up the language a bit and we say, who is your POA? But really the POA, the power of attorney for personal care, is a document. So a POA is not actually a person, it's a document that names a substitute decision maker.
Right.
So the second line is, does this person have a power of attorney naming a certain person or people to be their substitute decision maker? The third one is the last legal one, which is a representative. We won't go into a lot of detail, but after that, it goes into automatic family decision makers. So if you don't have any of those first 3 legal ones, we go into family decision makers. So it would be your spouse. After your spouse, it would be your parents and or children, and etc. Right? So the
adult children, right? It would be
adult children.
16 and over.
16.
16 to be a substitute decision maker.
Wow.
Yes.
Okay.
So what I learned when I first started doing this work was that it's really important for everyone, regardless of age, I would say 16 and up, to look at this hierarchy and know who would it fall to? Who would substitute decision making fall to in your life if you couldn't decide for yourself? And to make sure you have that right person in place.
Right.
Because if you're not happy with who it automatically falls to, it's really important to have a power of attorney for personal care, naming the person you would want to make decisions for you.
Right.
And the person you want making decisions for you is the person who knows you well, who could have these conversations that we're talking about, to know what's important to you if they had to make a decision on your behalf. So that's the first piece. The second piece is having meaningful conversations, right? Yeah. Who are you? Who am I? What's been important to me in my life? What do I think about dignity or independence? Or what are things I couldn't live with, or things I couldn't live without? Right. And sometimes those things are not what we think of. I think mentally we go to medical treatments, but sometimes the things we can't live without are sunshine and our feet in the grass, or, We've heard stories about, people wanting their hair dyed in hospice, like days before they die. These are the
They
things
want to eat shrimp every day. They want
yeah.
hot dogs. They just want all the things that they've denied themselves because, it was unhealthy, and they just want that.
Yeah. So this is the beauty of palliative care and a palliative approach to care, is that what we hope is that it's the first thing we always talk about, is trying to integrate quality of life for people through their illness trajectory up until their last day. And what quality of life looks like might change throughout the trajectory in illness, but how do we continue to zero in on an individual's, and an individual's, most important pieces that give them quality of life, and how do we as healthcare team members work, and family team members, I shouldn't just say healthcare, how do we all work together to try to improve quality of life for people up until their very last day?
Well, and that's really a process, because they don't always know what it is either. So that's the conversation piece in there, right?
And listening to what they say at this time as a family caregiver. When my parents were caring for my grandmother near the end, and she literally wanted garlic shrimp and homemade pierogies. That's what she wanted to eat. And my mom was just like, no, you need a balanced diet. And then her mom gave her trouble and said, why? Why? She's nearing the end. It's the joy she has. Pierogies make her think of her mom and her grandmother making them and learning how to make them because she was Ukrainian. Why wouldn't you give her these things? They're simple. They're easy. Do it. Makes her happy. And my mom was like, oh, yeah, you're right. Why wouldn't I? So, and I reminded her, so Mom, when you get to that stage, you want me to listen or do you want me to be you? She's like, I'd like you to listen. I'm like, because I'm starting to have a lot of conversations with my parents about this as well, because I see it daily, and I want the people I love to have as much power of their own decisions and everything that they can have for as long as possible. And, I have the power of attorney for my parents. So, I'm paying attention. I listen to what they want because I want to make sure that they get what they want, whatever it is.
Yeah, but thanks, Heidi. And that's exactly what we say, right? Like, while these conversations can be challenging, it doesn't, not having them is generally worse.
Right.
And more than challenging is they could be so meaningful.
You can learn a lot about each other too. I've learned a lot about my mom, talking to her about these things. And what okay, she's a bit of a tree hugger now. She's gone total hippie. and so I know what she she doesn't want to sell her house to just anybody and all this stuff. And so I am trying to give her the power, remind her she has the power now. That's awesome. Do what you can to give yourself that power now. And, and I always tell her, I'm like, why don't you renovate your kitchen? Well, when somebody buys this house in, 5 to 10 years, they're going to want to change it. So enjoy it for yourself. Give yourself the power of the joy of cooking in a kitchen that you finally want. Enjoy that. Enjoy the joy.
I hope she's hearing you.
I hope so too. We're not renovating their kitchen yet, but I'm hoping that they do it soon.
Yeah, definitely. So I'm going to bring up MAID, because that is, of course, part of what we encounter in terms of decisions that people make. Is that how do you approach that? Obviously you're not bringing it up, I don't imagine, but if somebody brings it up with you.
Yeah, right. I've seen people where they're saying to me repeatedly, I just wish I could make this end. I just want this to be over. And, unpacking that and understanding, what is that rooted in? Is that rooted in, the pain and the suffering that you're having, the symptom management? Because we can sort of alleviate a lot of your symptoms. We can look at improving your symptom management and taking some of the symptom burden away. Or is it truly rooted in, sort of that desire, informing people and, pointing them in the direction of dying with dignity and the Ontario legislation and saying this is what's needed. Oftentimes people think that they need a lawyer to actually proceed with MAID, but they don't. There's out of the Ottawa Hospital, there's the regional MAID network for this area that someone can self-refer to the MAID program if they so desire. That it depends, there's track 1, there's track 2, that's sort of the nitty gritty of MAID, but, unpacking with someone, what are your statements rooted in? Let's sit with that. Let's try to see, is that rooted in a desire to pursue something like MAID, or is it just symptom burden that maybe we can, work to tweak some medications or work to improve your symptom management so that maybe it doesn't seem like you want to end your life in the same way, or that you're not feeling those same sentiments. It is a tricky situation for sure. The religious aspect of it can make it tricky for different patients, and different loved ones have different opinions on it, that it can feel very political even within a family. So it's always a bit of a tricky thing to navigate, but, going with the patient and what the patient wants and what they are saying to me and running with that conversation. Sometimes I'll preface and say, I'm about to say something that if you never want me to say it again, or if you wish that I sort of don't say the statement, then I don't have to. But I just want to ask, with everything that you're saying, have you ever considered MAID? Or is that something that you are aware of or knowledgeable about? And this is people, when they do really have that life-limiting illness, oftentimes sort of the stage 4 cancers. But I will preface it to them and say, we never have to talk about this again. I'm just curious with everything that you're saying, and just helping people feel informed and pointing them in the right directions of where they can gain more information and learn more about it.
Mm-hmm. So for our listeners, if you're not aware of what MAID is, medically assisted induced death, correct? So just in case we've talked about it on the show before, but there may be new viewers. So yeah.
And it's always a heavy topic. It's a hard one to, bring up to loved ones and sort of making that decision. And I've seen people, they make that decision and then they sort of enter into a bit of a depression afterwards. They say, I want to end my life. Why can't I end it now? Because it's not an urgent service. It takes usually about a month when someone's track 2, when it's reasonably foreseeable. So it doesn't happen overnight, but then people have a hard time, sitting with, I've chosen to go this route, but why can't I get it tomorrow? Why can't I get it the next day? There's a lot of struggles, mental struggles that can come with that decision. It's a heavy one for sure, but it can be very empowering and, dignity, provide people a lot of dignity and of control. A disease has taken so much control from someone that I've seen it really empower people and get that decision back and some of that control back.
And I think the scope of like palliative care, we recognize that medical assistance in dying is one option, right? So I think that, there's no sort of promotion necessarily, and there's no denial, but like sometimes it's just people want to know what their options are, and MAID is one of their options.
It's probably a lot harder on the family members than anything else. I mean, I
think it depends. Like, honestly, Heidi, like I feel like I've seen families that feel very empowered and good and peaceful and about the MAID process, and others who have struggled, right? Like for a variety of reasons, like Lindsay said, like, I don't think there's just one, there hasn't just been one experience. Like it's very, it's very particular to each family and each case.
I remember recently I had a client, the client, her daughter, I was speaking to her and she called me and she told me that this is what her mother had decided. And she was just like, my heart is broken, but it's what she wants. And I was like, that is amazing. That is amazing as a daughter, a family member, to be able to say that. And I wish that if I'm put in that position, that I will still be able to be as supportive and understanding and still have my heartbreak and still have that pain, that grief, but stay strong for my loved one or parent who is making that decision. I love
that you came to that. So we have five things to know about palliative care. It's like an education we offer to a lot of different organizations. And the 5th thing is that a palliative approach is person-centered, which is what you're talking about, right? And I think it's really it's an important foundational piece of palliative care is to understand that each of us as human beings, we ultimately get to make these decisions, either ourselves or through our substitute decision makers, of how we want to handle illness, dying, death, right? And as family members, our responsibility, or as people, not just family members, but people who know people who are experiencing illness and dying, yeah, it's our job to do the best we can to support them in their decision, right?
Yes.
So
and it doesn't mean it has to be your choice. You don't have to decide that if you're in that situation, but be supportive of the person in their decision, whatever that decision may be, is probably the best thing you could do for yourself later on, because then you would eliminate that guilt and that grief. Well, the grief for going against what they wanted or anything like that.
Of course. Regret.
So it all comes back. Like, I love that, the title of your podcast here is Compassionate Conversations. And I think the crux of palliative care is often about conversations. Like, I think this is what it comes down to, right? We can't do these. We can't respond to these things well if we're not having conversations.
Yeah.
So,
which is the crux of why we started this podcast, for people to start to have these conversations and introduce it. And we're so thrilled that you came to speak with us today. So thank you so much for all your knowledge. We have reached the end of our hour, and I know that some have other commitments. So we'll just final word about palliative care from each of you. Just one sentence on what you would love people to know about it.
Lindsay?
Yeah, I think for me, really like early integration of a palliative approach to care can really start the conversations and help people feel empowered and informed. And really that's the goal, is to tailor care to them, to have that empowerment and that informed decision-making along the way.
Excellent.
Awesome. Thank you. And Tara?
Yeah, very similar. Like, for me, it's heart and soul centered, right? So, I think it's a lot about like all of us going in and then sharing with the people around us, and taking information and integrating it, and like being kind and compassionate and caring for each other, and just having these conversations early and often. And
beautiful.
Excellent.
Thank you
so
for having
much.
us today.
Thank you both for coming.
So much for having us.
Thank you. And for all our viewers, thanks for joining us, and come back and see us very soon. Take care.